Hello, my name is Natasha Sheybani, and today I'll be sharing with you our findings on an immuno-PET-informed paradigm for glioblastoma treatment with CD47 blockade and focused ultrasound. CD47 is ubiquitously overexpressed on the surface of most cancer cells, including glioblastoma, wherein its engagement with SIRP-alpha relays a don't eat me signal to phagocytic cell types such as macrophages. Thus, antibody-mediated blockade of CD47 can serve as a promising strategy for overcoming this mechanism of tumor immune evasion. In glioblastoma, the efficacy of anti-CD47 remains limited due to the challenges that the blood-brain and blood-tumor barriers, or BBB and BTB respectively, impose on systemic drug delivery to the brain. It's now well established that FUS, in the presence of circulating microbubbles, can locally and transiently disrupt these barriers, yielding improved antibody delivery and outcomes for glioblastoma. However, the timing of therapeutic administration relative to FUS remains a discrepant parameter within the literature. In order to evaluate the impact of therapeutic sequencing on FUS-mediated antibody access, we designed a study utilizing the GL261 model of murine glioblastoma, which is known to richly express CD47. 14 days following orthotopic implantation of GL261 cells, we systemically administered a zirconium-89 labeled mouse CD47 antibody, or mCD47, and then we performed MRI-guided barrier disruption with FUS. We evaluated two different sequencing protocols in this context, one in which the radio-labeled antibody was delivered immediately prior to sonications, and another in which the antibody was delivered about 15 minutes following sonications. Following these interventions, we spatiotemporally mapped antibody penetrance via serial PET-CT imaging and confirmed ex vivo biodistribution at a terminal time point via automated gamma counter measurements. In today's presentation, I'll focus on the results of serial immuno-PET imaging. On the left are representative decay-corrected PET-CT images for naive or GL261-bearing mice having received radio-labeled mCD47. Quantification of standard uptake values from these images revealed that relative to a brain with fully intact BBB, the EPR effect in GL261 tumors did little to improve mCD47 delivery. Interestingly, the dogmatic protocol involving antibody injection immediately prior to barrier opening did not improve mCD47 penetrance beyond the baseline for GL261 tumors. Strikingly, however, when we switched to the protocol administering antibody after sonications, we observed superlative uptake. On average, the blue bars here represent anywhere between a 4 to 7-fold increase relative to control groups. And I'd like to here emphasize that this elevated access was sustained over multiple days following the initial intervention. We next leveraged these insights to deploy a repeat barrier opening paradigm performing post-FUS mCD47 delivery. And as depicted by the stratification and tumor volume here at day 20, mCD47 delivery with FUS markedly constrained GL261 outgrowth relative to monotherapy. Our evaluation of overall survival is best contextualized by comparison to a recent Science Translational Medicine paper from Irving Weissman's group, where you can see that the same clone of mCD47 was delivered at 2 different doses in GL261. The lower dose indicated here required a total of 27 injections, or approximately 432 mg per kg of mCD47, in order to achieve the depicted survival benefit shown here. Now I overlay our survival results, and hopefully you can appreciate the stratification between control and treated groups is comparable. However, I note a remarkable difference. We achieved this stratification with just 3 systemic administrations of mCD47 at a dose of 8 mg per kg, meaning that we were able to achieve a similar effect with an 18-fold decrease in administered drug. Given the notorious challenge of on-target off-tumor toxicities across many immunotherapies, including anti-CD47, this finding underscores the tremendous potential of FUS as a tool for conferring drug delivery at therapeutically meaningful levels while significantly curbing risks of toxicity. To conclude, this study offers us important insights into the role of therapeutic sequencing relative to FUS, and also provides a promising strategy for treatment of glioblastoma with FUS-mediated CD47 blockade. Most importantly, I hope that our findings have impressed upon this audience the unequivocal impact that nuclear medicine tools can have on the design and monitoring of FUS treatment protocols going forward. To close, I'd like to thank my advisor, Dr. Richard Price from UVA, as well as the many colleagues and collaborators at UVA who have made this work possible. I've highlighted their names here in yellow. And lastly, I'd like to thank our funding sources and all of you for your kind attention.